Hello, everyone. I'm really very sorry that I'm not able to join in person today, but I feel like this is just kind of par for the course with COVID lately. I want to thank all the previous speakers for wonderful talks, and now I'll try to shape some thoughts about when we should abandon these ultra minimally invasive techniques for really good old fashioned minimally invasive surgery. So there will be some overlap between the colon and rectal data, so I'll try to highlight each at the top of the page to keep them sorted out for you guys. So nowhere is the morbidity of our surgery more evident than when we do pelvic dissections. There's a lot of controversy and push to do these cases less invasively. And although we've had some recent advances that broaden our choice of sphincter saving procedures, this can be met with significant drawbacks. So the patients will usually have to undergo a temporary diverting stoma, which does require an additional procedure to restore their continuity. It also still involves a permanent colostomy in about 10 to 30% of patients, and it can account for significant risk of complications. So our postoperative mortality rate can range between 2 to 5%, and postoperative morbidity about 20 to 30%. And this is probably even higher, maybe around 30 to 50% when the patients have undergone preoperative radiation. So this begs the question, how can we do better for our patients? And this goes well beyond just cosmesis for these patients. We're talking about decreasing morbidity, having quicker recovery, and really the reduced cost if you factor in the lack of a significant hospital stay. So organ preservation is highly desirable, but we have to consider at what price. So when does this become a case of hype versus reality, where you have all of these fancy new tools and tricks of the trade, but the patient may really be better served with the tried and true? So especially now with enhanced recovery pathways that decrease our patient's length of stay, we may not have such a drastic difference between the two groups. So let's try to pose a few scenarios where conventional surgery may actually be the better choice. So when the endoluminal surgery may actually be oncologically inferior is probably most applicable to early rectal cancers, because I hope that we're not doing inappropriate ESDs unless the patient is seriously comorbid. But the biggest question here really is regarding the lymph node status that is still really difficult to stage. So the risk factors for nodal mets in the setting of early T1 cancers include things like submucosal invasion, and this is greater than 1 millimeter, so this puts the patients in the SM2 or SM3 category for the Kikuchi classification. Also things like lymphovascular invasion, poorly differentiated tumors, tumor budding, and any one of these risk factors present on final pathology should lead the surgeon to go on to recommend an oncologic surgery because of the higher risk of lymph node metastasis. So even in this recent review article, they reference significant morbidity and long-term effects on anorectal, urinary, and sexual dysfunction after proctectomy. They also talk about the reality that patients may still require permanent stoma, and almost 20% of patients with a diverting stoma will never have it reversed. So even still, local excision is only suitable as a curative procedure in early cancers with low risk of lymph node mets, considering the local lymph nodes are not adequately addressed with these local techniques. So when should endoluminal surgery be avoided in the first place? This may be most obvious in colonic lesions. Previously, we considered polyps larger than about 1 centimeter with advanced morphologic features, weren't really amenable for endoscopic removal, and surgical resections were common. But really, if you look back, probably more than 92% of those, the final pathology didn't even reveal any malignancy. So the current opinion is that lesions larger than 2 centimeters, that an advanced polypectomy is probably more beneficial, and that should be managed by an advanced endoscopist. So there are several consensus guidelines from Korea, Japan, Europe, and the US, and they've all kind of agreed on several statements. So before the advanced endoscopic resection should take place, all of these lesions should undergo a complete assessment, looking at the morphology, the surface, and the vessel pattern. This needs to be done by an advanced endoscopist, hopefully the person who's actually going to be doing the polypectomy later. And many times this will use dye-based chromoendoscopy or image enhancement such as narrowband imaging so that they can identify those lesions that have features that are suspicious for deep submucosal invasion of cancer. So when any of those endoscopic features are present, the biopsy should be taken from those areas and the patient should be scheduled for staging studies kind of in anticipation that they will eventually need surgery. So this goes for both pedunculated and non-pedunculated polyps. And again, some of those classification systems using the narrowband imaging are the NICE classification. Patients with type 3 lesions will have this disruption of the surface pattern and the vessel structure, which can be quite specific for deep submucosal invasion. Also, we talk a lot about the Kudo pit patterns, and type 5 can be broken down further into these non-structural or irregular patterns that would also portend that the patient likely has deeper invasion. So any of these features should preclude endoluminal surgery and the patient should go straight to conventional surgery. So these are just a few tables showing with the narrowband imaging, that NICE classification, what the type 3 would look like. And also these Kudo pit patterns, the 5I and 5N, that would be more suspicious for a deeper lesion. And this is a picture of what that would kind of look like. So again, going back to rectal cancer, as these will likely be addressed with TEM or TAMIS surgery, that it's pretty understood that this is a safe approach for these early rectal cancers, a T1 and 0, that can be tackled with this type of local excision. But really that T2 lesions should follow the standard of care with a proctectomy if the patient's fit for surgery. Now, one caveat to this could be that if the T stage is in question, the local excision can be done kind of as a big biopsy to help guide any further steps. So when would we want to abort to convert to an oncological bowel resection? So again, this is going to bring us back to the colon and to ESD. And the big thing here is that if the injection is in the correct plane, but there's really not an adequate lift, this so-called non-lifting sign, that this could be a sign of deep invasion into the submucosa. And if this is encountered during the procedure, then it should be stopped. But recently, this group also looked at the amount of non-lifting that can happen if the patients had previous attempts at resection or biopsy, because this can cause some fibrosis in those layers and prevent the lifting from happening. And in those cases, you can probably still proceed safely with the ESD, just knowing that you may need to do further surgery after. And when should this be followed up by an oncologic bowel resection? So let's remember some of our previous risk factors. We talked about the Kikuchi level or classification in the submucosa. So we have submucosal invasion that's greater than 1 millimeter, presence of lymphovascular infiltration, poorly differentiated tumors, tumor budding, and of course an incomplete resection. And these are all independently associated with an increased risk of lymph node mets and residual cancer. So how feasible would surgery be after an ESD or maybe a TEM, TAMIS local excision? And what do we find out on our final pathology? So this first study looked at 51 patients with colorectal cancer who went on to have additional surgery after a non-curative ESD, and you can see the reasons here that they were classified as non-curative. So after the surgery, the final pathology identified 5 patients, or 10%, with positive lymph node mets. And lymphovascular invasion was the one thing, the independent risk factor that they found that was associated with lymph node mets. So now let's focus on rectal cancer with the CART study. And this was a prospective multi-center study trying to quantify the number of patients with minimal residual disease, so YPT0 or 1, after neoadjuvant chemoradiotherapy by using TEM to assess their response. So patients with clinical stage T1 to 3 with no nodal disease in distal rectal cancers were treated with long course chemoradiotherapy. Those that had a significant downstaging down to T0 to 2 underwent TEM 8 to 10 weeks after the last dose of their radiation therapy. So 47 of these patients went on to have TEM after they were downstaged. The large majority were T1s. One had nodal disease. This is the one that would probably scare me the most. The second largest group were the T2s. And then even still, one was a T3 lesion, which maybe shows that our staging scans can still be incorrect. So all the patients that had T2 or T3 pathology after their TEM were recommended for a completion proctectomy within 4 to 6 weeks. Half went on to have surgery. 2 of them had LARs, 6 of them had APRs, because remember that we're talking about very distal rectal cancers. And fortunately, none of the specimens showed any residual disease. So the other half declined surgery, and about a third of them actually developed a local recurrence. So their conclusion was that TEM after chemorads enables organ preservation in half the patients with rectal cancer. My interpretation of this is that the other half of the patients benefited from a completion proctectomy, even though the final path had no residual tumor. So I'm sure all of us have had to deliver news before that there is no viable tumor cells present in the specimen after you do a proctectomy, but I would much rather be in that situation than telling a patient later that their cancer has recurred. So sticking with rectal cancer, the next study looks at outcomes of completion proctectomy after a TAMIS local excision. So they found no significant differences in their operative time, blood loss, complications between the completion proctectomy group after TAMIS versus a group that went straight to primary proctectomy. There was also no 90-day mortality in that completion proctectomy group. There was a difference in the intact grade of the mesorectal fascia. It was incomplete in 3 patients, or 15% of those that had the completion proctectomy, versus no breaches in the TME plane after the primary proctectomy. So there were no local recurrences in either group, and their 1 in 5 year disease-free survival was comparable. So this is really, not considered to be too bad as a salvage after a local excision. But unfortunately, these stage procedures don't really come without consequence. So we talked about improved function with organ preservation, but actually symptoms similar to a low anterior syndrome are still quite common in patients who have TEM after chemoradiotherapy, with about half of those patients experiencing symptoms consistent with this. Anxiety is also a real issue, especially for the patients who were not complete responders compared to those that were. And lastly, the patients who undergo a completion proctectomy after this local excision seem to have much higher rates of morbidity than patients that underwent just a local excision alone, or the patients that went straight to completion proctectomy after chemoradiation. So going back to our rectal cancer guidelines, local excision after neoadjuvant therapy can be offered in a trial setting, especially for patients who aren't fit for or refuse to have major surgery. For those patients with low risk PT1, then that local excision should be sufficient to treat them. Those that have high-risk T1s following that local excision should go on to have a completion proctectomy. And of course, as we discussed before, standard of care after local excision, if the path is found to have a T2 rectal cancer, should also be a completion proctectomy. Now, in some other settings, adjuvant, mainly chemo, sometimes radiotherapy, following local excision for those patients who have high-risk T1 or T2 cancers is an alternative to doing a completion TME, but this should be done really in the setting of a clinical trial, especially with those patients that are unfit for surgery or who refuse to have surgery. So as we discussed earlier, organ preservation is desirable for many different reasons for our patients, but shouldn't be maintained or pressured to the patient at any price. There are a lot of new technologies and techniques out there that are always very exciting to attempt, but we need to recognize the indications for these and the limitations of these approaches whenever we're talking to patients about their different treatment options. We also need to be able to identify conditions and circumstances in which the patient's safety requires our normal conventional oncologic resection rather than a novel approach to make sure that they have adequate outcomes. So I want to thank SAGES for having me as co-chair of this session and also allowing me to still present virtually under these wonderful circumstances. I hope everyone has a wonderful meeting. Thanks so much.